Breast milk jaundice versus breastfeeding jaundice. Does breastfeeding affect jaundice in newborn? Absolutely yes. Breastfeeding affects jaundice level in a baby by two ways. First, breastfeeding jaundice. Second, breast milk jaundice. In today's video, we will discuss what is breastfeeding jaundice, what is breast milk jaundice, are breastfeeding jaundice and breast milk jaundice same or different, till when breastfeeding and breast milk jaundice persist, why this jaundice occur at the first place, basic pathological mechanism behind these two, what should be done if a baby gets breastfeeding jaundice, how to diagnose and treat breast milk jaundice in a baby. So let's get started. What is breastfeeding jaundice? It is also called lack of breastfeeding jaundice or suboptimal jaundice. Suboptimal jaundice is a better terminology. Breastfeeding jaundice is the jaundice that happens due to reduced intake of breast milk, either due to decrease in frequency of feed or due to lactation failure, that is, mother not producing enough breast milk. Why breastfeeding jaundice occurs? Because of reduced breastfeeding, there is decrease in gut motility. This enhances enterohepatic circulation of bilirubin. Hence, more bilirubin gets deconjugated and reabsorbed from gut and decrease in bilirubin excretion in stool. This causes unconjugated hyperbilirubinemia. This is the mechanism of breastfeeding jaundice. Rise of bilirubin in breastfeeding jaundice. Usually bilirubin is raised but not too high. Nevertheless, it contributes to neonatal jaundice. Timeline of jaundice in breastfeeding jaundice. Jaundice usually starts on day 2 to day 3, increase to peak between day 5 to day 15, then it comes down on its own in another 2 to 3 weeks. In other words, breastfeeding jaundice is apparent in first week of life while feeding is still being established. Other associated symptoms in breastfeeding jaundice. In breastfeeding jaundice, baby may have excessive weight loss of more than 10% of birth weight, dehydration, and reduced urine output also. Also, there can be delayed passage of meconium along with it. Meconium is first stool of a baby that is loaded with bilirubin. Slow passage of meconium causes bilirubin to get absorbed from it. Treatment of breastfeeding jaundice. Frequent feeding. Giving breast milk frequently, that is every 2 hours and on demand, will increase breast milk production. It will reduce enterohepatic circulation and in return reduces jaundice. Plus, it will also improve calorie intake and treat dehydration that helps in weight gain of baby. Let's discuss breast milk jaundice. History of breast milk jaundice. In the year 1963, Arias et al. Discovered a condition where few newborns who are exclusively breastfed presented with jaundice or unconjugated hyperbilirubinemia, which continued beyond second or third week of life. It persisted up to few weeks or months if breastfeeding is continued and then resolved spontaneously. This jaundice is termed as breast milk jaundice. It was believed to be due to presence of some substances or factors in breast milk. What is breast milk jaundice? Definition. It is a type of indirect hyperbilirubinemia in an otherwise well-thriving healthy breastfed newborn that usually starts after day 4 of life and persists longer than physiological jaundice without any other identifiable underlying cause. Characteristic of breast milk jaundice. Breast milk jaundice is characterized by prolonged hyperbilirubinemia, jaundice that lasts more than 2 weeks in term and more than 3 weeks in preterm baby, and in hyperbilirubinemia, that is direct or conjugated bilirubin is less than 2 mg per deciliter and less than 20% of total serum bilirubin. These two conditions must be met to tell it is breast milk jaundice. How common is breast milk jaundice? Prevalence. If we take 5 mg per deciliter as cutoff, then approximately 20 to 40% of exclusively breastfed newborns develop breast milk jaundice. And if 10 mg per deciliter at 3 weeks of life is taken at cutoff, then around 2 to 4% of exclusively breastfed baby develops breast milk jaundice. It is interesting to note that breast milk jaundice is most common cause of prolonged unconjugated hyperbilirubinemia in newborn. But to say it is breast milk jaundice, other causes of prolonged jaundice must be ruled out. Why does breast milk jaundice occur? Etiopathogenesis. Exact reason why breast milk jaundice occurs is still not known, but following theories explain it. First, due to breast milk itself. Second, due to newborn causes. Breast milk causes. There are certain factors in breast milk that lead to breast milk jaundice. 6 such factors are identified. First, beta-glucuronidase. This enzyme deconjugates bilirubin di and monoglucuronides. Hence, bilirubin is released, causing unconjugated hyperbilirubinemia. Second, pregnanediol. This is a substance in breast milk of few mothers which inhibits glucuronil transferase enzyme in liver, hampering conjugation of bilirubin. Third, free fatty acid. This also has the same mechanism of inhibiting glucuronil transferase enzyme in liver. Fourth, interleukin 1 beta. It has cholestatic effect leading to hyperbilirubinemia. So it plays some role in jaundice. Fifth, epidermal growth factor. It is another factor. It reduces motility of gut and also enhances absorption of bilirubin and increase in enterohepatic circulation of bilirubin. Some mothers' breast milk has higher concentration of epidermal growth factor, leading to breast milk jaundice. Alpha-fetoprotein. It is another factor in breast milk that has some role to play in increasing jaundice. However, the underlying mechanism is not yet known. Now come to neonatal causes. Some newborns are genetically suspected to develop breast milk jaundice. Studies have identified a mutation in UGT1A1 gene. Mutation in its coding portion lead to defect in UGT enzyme in liver, which results in breast milk jaundice. It is interesting to note that mutation in regulatory portion of UGT1A1 gene lead to Crigler-Najjar syndrome and Gilbert syndrome, which are two differential diagnoses of breast milk jaundice. What are symptoms of breast milk jaundice? When baby is in hospital at around 72 hours of life, serum bilirubin is checked or ectasis assessed in baby by physician. But after baby is discharged, if it develops jaundice, then it shows up as increase in yellow discoloration of eye, skin. It starts from face, progress to chest, abdomen, leg, and finally to sole. Baby also develops yellow urine, so parents need to be watchful. Breast milk jaundice happens in an exclusively breastfed baby. Baby is thriving well, that is gaining weight adequately, apparently healthy and passing urine and stool well. A physician then does a series of tests and clinical assessment to diagnose it as breast milk jaundice. How long does breast milk jaundice persist? Timeline of jaundice. Breast milk jaundice starts around day 4 to day 5, peaks at around 2 weeks, persists for 8 to 12 weeks if uninterrupted breastfeeding is continued. It resolves slowly but spontaneously without any intervention. Hence, prognosis is usually good. Evaluation of breast milk jaundice. Differential diagnosis. In breast milk jaundice, there is prolonged unconjugated hyperbilirubinemia. To diagnose it as breast milk jaundice, other causes of hyperbilirubinemia should be excluded. First is jaundice which are not prolonged. Second group is jaundice which are prolonged. Physiological jaundice and breastfeeding jaundice are two types of jaundice which are not prolonged. These usually last up to 2 weeks. If it is a prolonged jaundice that is last more than 2 weeks, then see if it is conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia. Conjugated means when direct bilirubin is more than 2 mg per deciliter or more than 20% of total serum bilirubin. Unconjugated hyperbilirubinemia when direct bilirubin is less than 2 mg per deciliter and less than 20% of total serum bilirubin. In direct hyperbilirubinemia, baby has often clay colored stool or white colored stool instead of yellow. If it is direct hyperbilirubinemia, then rule out neonatal hepatitis, extrahepatic biliary atresia, and choledochal cyst. If it is unconjugated hyperbilirubinemia, then see if it is hemolytic or not hemolytic. Tests like hemoglobin, hematocrit, peripheral smear, retic count, DCT, and sometimes genetic tests are done to rule out hemolytic causes of prolonged hyperbilirubinemia like ABO incompatibility, G6PD deficiency, hereditary spherocytosis, and other antibody-mediated hemolysis. Non-hemolytic causes. If non-hemolytic but it is prolonged jaundice, then following causes should be excluded. First, Crigler-Najjar syndrome. Second, Gilbert syndrome. If unconjugated hyperbilirubinemia prolongs longer than what is expected for breast milk jaundice but no hemolysis, then rule out these causes. Third, hypothyroidism. Fourth, galactosemia. These are also causes of unconjugated hyperbilirubinemia without hemolysis. After excluding out all other causes of prolonged jaundice, finally breast milk jaundice diagnosis is made. Treatment of breast milk jaundice. If rise of bilirubin is below phototherapy range, then no treatment is needed and continue breastfeeding. If it crosses phototherapy range, then start phototherapy and continue breastfeeding. If serum bilirubin is more than 20 mg per deciliter, then phototherapy should be continued along with brief stoppage of breastfeeding for around 24 to 48 hours. During that period, baby should be given pasteurized donor human milk or formula milk. Mother should express out her milk and throw it during that period. When breastfeeding is re-established, then bilirubin will rise but not to the same rate as before. Point to remember here is breast milk jaundice is the most common cause for prolonged unconjugated hyperbilirubinemia for more than 14 days of life. However, other causes of prolonged hyperbilirubinemia should be ruled out to say it is breast milk jaundice. Difference between breast milk jaundice versus breastfeeding jaundice. Breast milk jaundice occurs due to chemicals like pregnanediol and glucuronidase in breast milk, which cause unconjugated bilirubin to rise. On the other hand, breastfeeding jaundice occurs due to reduced breastfeeding or suboptimal breastfeeding. Breast milk jaundice appears around 2nd to 3rd week of life, whereas breastfeeding jaundice occurs mostly on 1st week. Breast milk jaundice persists for several weeks if breastfeeding is continued, whereas breastfeeding jaundice subsides by 2nd or 3rd week on its own. Breast milk jaundice occurs in a well-fed baby where breastfeeding is already established. Feeding jaundice happens when breastfeeding is still being established. Breast milk jaundice is less common. Breastfeeding jaundice is significantly more common than breast milk jaundice. In breast milk jaundice, baby has good weight gain. In breastfeeding jaundice, baby have excessive weight loss of more than 10%. In breast milk jaundice, there is no dehydration. Breastfeeding jaundice may have dehydration. Frequency of urine and stool is normal in breast milk jaundice. There is reduced frequency of urine and stool in breastfeeding jaundice. Brief interruption of breastfeed for 1 to 2 days will reduce jaundice in breast milk jaundice, whereas decreased frequency of breastfeed will aggravate, whereas increased frequency will reduce breastfeeding jaundice. Rise in bilirubin may be very high, up to 10 to 30 mg per deciliter, and may need phototherapy in breast milk jaundice, whereas rise in bilirubin is not high but contribute to jaundice in breastfeeding jaundice. Conclusion. In all cases of breastfeeding jaundice and most cases of breast milk jaundice, it is advised to continue breastfeeding because benefits of breast milk outweigh risk of jaundice unless serum bilirubin is too high. Thank you for watching today's video. If you really liked it, then hit the like button, share this video with your friends, and do subscribe to Pediatric Simplified. Disclaimer, this video is for educational purpose only. For medical advice, kindly consult your physician.